Cocaine is the most commonly used stimulant in the Western world, with more widespread use than ever before. Intranasal use can be associated with irreversible damage to the nose and surrounding tissues, which urgently need to be brought to the attention of the public. So, as cocaine use becomes more prevalent, can ENT surgeons expect to be faced with an increasing number of patients with cocaine-related nasal deformity? This is EUFOREA News, broadcasting from London. Hello and welcome to EUFOREA News. I'm Dr. David Bull. Cocaine is the most commonly used illicit stimulant in both the United States and Europe. More than 4% of young British adults have used cocaine in the last year, and nearly 20% of US adults have tried it at least once. It's still mostly a drug of young people, but it is the only drug for which rates of use are rising in adults over 40. These are so-called silver snorters. Consumption of the drug peaks at the weekends, and that can be demonstrated by spikes in cocaine metabolites found in the analysis of wastewater. Cocaine is derived from the leaves of the erythroxylon plant. It's a plant native to South America. The leaves can be toasted and mixed into a paste that can be chewed, but because it is rapidly hydrolyzed in the stomach, users prefer to inhale a powdered form, which is cocaine hydrochloride. To maximize profit, dealers add bulking or cutting agents, and these can make up as much as 80% of the powder. These agents include phenacetin, caffeine, lidocaine, which mimics the numbing effect of cocaine, and increasingly levamisole. Use of cocaine can also cause serious cosmetic and functional disabilities of the nose. Well, here to tell us more is Professor Alwyn. He's a consultant otolaryngologist and facial plastic surgeon at University Hospital Lewisham, King's College in London. He's also president of the European Academy of Facial Plastic Surgery. Very good to see you. May I start by asking you, how often do you see nose problems related to cocaine abuse? How big is the problem?
So the problem is absolutely, I would say, it's a massive problem. So in my clinic, I would say in every single clinic, I would see possibly one, sometimes 2, 3 patients. That's, every day of the week almost. So it's a significant problem, and it is increasing actually.
And just in terms of that, that was going to be my next question, actually. Is the prevalence increasing? You've obviously said, yes, it is. Are you surprised by that?
I'm not surprised, because I think there are probably a couple of reasons for it. Because I think one is that people don't think that it's a dangerous drug as such. And secondly, I think there is so much kind of emphasis on socially joining, and certainly in the area that I work in London as such, I think it has become almost a socially accepted norm to have a little bit of cocaine when one goes out in the evenings, for example. And I think that then spills over into lack of control in terms of how much people use and how often they use. So I'm not totally surprised, I must say.
I couldn't agree more, actually. So let's break this down. In terms of inhalation of cocaine, what does it do in terms of the short-term effects?
Okay, so immediately when you start inhaling cocaine, it gives you a sense of excitement. It gives you a sense of euphoria. You feel good. You feel confident. And I think it actually helps you with the thought process, which flows probably much quicker in many ways. And I think it gives you more energy, for example. And that's why typically people take it after they've had a long day and they want to come up with some more work. And that's what it does to you. It is the excitement that it causes, and the excitement is not just because of increased brain activity, but it's also generally your heart, starts pumping a little bit more. So it's an overall feeling of excitement and more energy.
And just in terms of the short-term side effects for the nose, what does it do in terms of the vascular supply to the nose, the nasal congestion, and so on?
Yeah, so cocaine is a drug that causes what we call as a vasoconstriction. What that means is that the caliber of the blood vessels actually becomes smaller. So, and on top of that, it reduces the blood flow that goes into the nose because of that decreased caliber of the blood vessels, and you tend to breathe better. So you feel that you're breathing better, but it's not just the cocaine that causes problems, but it's the other stuff that's mixed with cocaine is generally, in my opinion, is a bigger problem.
In terms of what you've said, obviously the problem with cocaine is the cutting agents, which I talked about at the beginning of the show, but also the fact is that when you start taking cocaine, you want more and more and more. In terms of the patients that you're seeing, what about those people who have repeated use of cocaine? What sort of pathology do you then see?
Okay, so with the repeated use, really, I can break it down into two parts. There is one group of patients who repeatedly use cocaine, who use cocaine for a while, but they have actually used, I would say, slightly purer versions of cocaine. So they have less of a problem as opposed to people who have had various drugs and various chemicals that are mixed with cocaine. And what happens in those people is the lining of the nose breaks down. So as soon as the lining of the nose breaks down, the cartilage of the nose, that's the cartilage is the one that supports the nose, and the midline partition of the nose, what we call the septum, is made out of lining and midline support, which is the cartilage. The blood supply that goes to the cartilage gets cut off. So then you start, noticing breakdown in the cartilage and the lining. What that means is a little hole in the septum, what we call as a perforated nasal septum. Now, when you get a perforated nasal septum, the nose will start getting blocked because the mucus that's made in the sinuses and in the nose doesn't flow nicely as it should to the back of the nose into the throat. That's what normally happens. That mucus gets stuck. When that mucus gets stuck, then you get more of crusting and scabbing. And the tendency, as you know, is that people will pick the nose because they want to get rid of the crusting and scabbing. And then you're damaging the nose even more by picking. So it's scabbing, crusting, then picking of the nose that leads to actually minor bleeds from the nose. And that vicious cycle just continues on and on. So that's the basic of what happens. And over a period of time, as the hole gets bigger and bigger, the support to the nasal wall and the top of the nose, as it were, actually is lost because the septum, that's the midline partition that holds the nose up, can't actually support it. So you get what we call as a saddle nose or a cocaine-related saddle nose. And with the saddle nose, because the nose is also shrinking and coming down, the skin contracts. So you have a perfect combination of a nose that is collapsed, on top of which the skin has collapsed with less blood flow into the nose. So from there on, all the other problems like breathing, scabbing, bleeding, crusting, those things start off.
So essentially you're saying this causes irreversible damage. How much cocaine do you have to take, or how regularly do you have to take it to get the breakdown of the septum and then all of the pathological changes you talk about?
Okay, I think that is a difficult question in terms of how much and how often. The reasons being, it is not just a quantity, and it's not also the frequency, but it is also what that cocaine is mixed with. So I would generally say to anybody who is listening to this, even once or twice is probably not good for you because you actually start getting used to it. But I think anybody who has taken cocaine over a period of, let's say, 3 months or so, will start noticing those changes.
So when patients come to see you, are they actually honest? Do they confess that they're using cocaine, or do you have to have a high index of suspicion?
That's a great question. you do have to have a high index of suspicion, because majority of the patients do not admit that they use cocaine. And this is often not because they don't want to tell you, but they find that it is a taboo to tell anyone they're using cocaine. So I would say the older the patient, the less likely they are, to tell you. But the younger patients often tell you. So I ask these patients a leading question. In every nasal patient, I ask them a question: do you actually use recreational drugs, or have you used recreational drugs? So these are the two questions I always ask them. And majority, I would say, almost all of them then admit to it.
So interesting. So I've got the paper in front of me. You've published a paper on care of the cocaine user with nasal deformity. How do you go about treating these patients? Because it's incredibly complex.
Yes. I think number one thing is the patients have to trust you. That's the most important thing, because when these patients come to me, they are desperate. They have often seen other surgeons, other people. So you need to be very honest with them, and you have to tell them what your pathway is and how you're going to treat them. So I generally, first of all, I ask these patients, are you still taking cocaine, and do you intend to stop? Now, if they say, well, I have had very little cocaine, or I'm still taking, the next step is really to try and get them to stop taking cocaine. And we often have to use psychologists to help us with that process. And then also it's managing the nose itself. For example, for the nose itself, you want to minimize the suffering that they have. That means you want to minimize the nosebleeds, you want to minimize the scabbing and crusting, and often they get bad smell through the nose, and all those things. So for that, we use nasal rinsing and various other products, nasal sprays and things like that. And after that, we talk about actually how we go on managing and rebuilding the nose.
Well, it's been an absolute joy and pleasure to talk to you. Thank you very much indeed. Professor Alwyn de Souza.
Thank you very much, and thank you for having me. Thank you for your time.
Well, joining me now is Dr. Adam Chaker. He is a EUFOREA, CRS and EPOS panel member and Rhinologist in the Department of Otorhinolaryngology at the Technical University of Munich in Germany. Very good to see you. Thank you very much indeed for joining me. I was just talking to Professor de Souza about the prevalence, the use of cocaine generally. I'm just really interested to know, do you also see an increasing prevalence in nasal problems related to using cocaine abuse in Germany?
Well, I think in Germany we see an increase in use, and we see an increase also in associated second line complications. To be quite upfront, I have the impression that our exposure in a tertiary referral center in a university hospital is rather moderate. We see these patients occasionally, and then depending on what is actually the main reason why they address our hospital, we will accordingly advise them how to treat that. For instance, if patients, especially younger patients, who are physically active and where you have the impression they do not fit to this kind of patient group, suffer from heavy nasal bleedings, for instance. Then I think one of the important questions, especially if this goes along with high blood pressures, that you also evaluate whether cocaine abuse is involved. These are not the patients who would come for chronic problems of their nose. They simply come because of their not stoppable nasal bleedings that usually involve the sphenopalatine artery. And if this is like a 25-year-old person and has, let's say, a potential for, let's say, specific exposure, then you should ask the question. Another patient would probably be like rhinitis without reasonable cause, where you try to find out what is the reason. Another patient could be that you have an impression this is a patient who is extremely demanding, which is a cocaine typical personalities. So I think there's quite variety. And then you have those patients who suffer from very strange phenomena where you see like very rare masses or tumors or ulcers in the nose, where you think this is a very strange reason, and you think it may be autoimmunity, but it is not. And then you start asking the patients, because there may be like a kind of polytox reason behind that, or only cocaine reason behind that. So this would be like the major groups I would look at.
So I was talking to Professor D'Souza, and we were talking about the cutting agents. We're seeing increasing amounts of cutting agents being used in cocaine that's freely available in many countries. So, I mean, this is probably quite a difficult question to answer. What, in your opinion, does the biggest damage? Is it the cocaine itself, or is it the cutting agents, or is it actually a mixture of both?
This is a very interesting question, and I think to obtain credible information on this is very difficult, because we can't do clinical exposure studies and alongside control the degree of cleanliness of the exposure substance. It is not so long ago that we learned that there used to be chemical cutting agents in these drugs that are taken via the nasal mucosa, especially also in cocaine, and this would also involve mechanical grinding substances. Even glass was described, and this seems to be not an issue anymore. But there seem to be substances that are used as agents that also can amplify the pharmacology of cocaine, but they have other undesirable side effects. I think from its mechanism of tachyphylaxia, cocaine per se will have also side effects on the nasal mucosa simply because of how it acts, simply leading to atrophic, chronic, dry, and even ulcerous rhinitis. But these cutting agents may worsen these things, may amplify it, or may even hide this because they develop like a different way of compensatory remodeling strategies in their mucosa, these patients. It's so difficult, and we are not dealing with, as you have said it at an earlier stage, patients that will be honest about what they do and how they use it. So I really have problems to allocate what of the side effects or problems do we see is linked more to the agents that used like adjuvants or to the cocaine itself. It's very difficult. Unfortunately, this kind of concept, even though we offer it, is usually not embraced by these patients. So my personal humble experience with these patients is, in most of the cases, we don't change their lives, unfortunately.
And so I think there is this misnomer, or at least this what misunderstood kind of truth. People think cocaine is a safe drug, but what message finally can we send to the wider community, to patients, to lawmakers, to physicians? What are your personal thoughts?
This is a very questionable view on it. I think no drug is safe, not even alcohol. It is a question whether a society knows how to handle the intake of drugs in a responsible way. Now, while we have, let's say, long tradition for alcohol, we still see how huge are the side effects for society. I'm not a specialist for addictions. My personal advice with all these patients always is, if you think that you have a problem and we can offer you a solution, and please come to us and we help you to find the right treating physician in the toxicology department, in psychiatry, wheresoever, to support you. This is what we do. For policymakers, I have the advice that people who claim that the use of drugs is safe should provide the evidence, because what we see is that actually no drug is safe, even those where we know how to handle them, or we think that we know how to handle them since many thousand years. So I'm a bit skeptic with that. On the other hand, in a way, it is a human way of recreation. Unfortunately, that's what people do. they go for a wine, and some have cannabis products and other ones use cocaine. What we see is only the tip of the iceberg.
Well, very wise words indeed. No drug is safe. Thank you very much indeed, Dr. Adam Chaker.
Thank you.
Well, that's it for this EUFOREA news. Many thanks to my guests, to Professor Alwyn de Souza and Dr. Adam Chaker. Really, really fascinating stuff. Now, you can find more information about EUFOREA and register for the EUFOREA educational events on the euphorea.eu website, where you can also sign up to receive the latest news via email. And don't forget to follow us on social media on YouTube, Twitter, LinkedIn, Instagram and Facebook. Until next time, goodbye.